All right, let's jump right in. We're going to talk about one of the most complex and frankly tricky cancers on the planet.
We're talking about peripheral T-cell lymphoma, or PTCL. For the longest time, this disease has been a total nightmare for doctors, a real puzzle. But the good news is, we're going to uncover the scientific breakthroughs that are finally, well, they're turning the lights on, moving us from just pure guesswork to actual precision medicine.
Okay, so first things first, we really have to get a handle on the fundamental challenge here. What exactly is PTCL, and why has it been so darn hard to fight for so many years?
See, PTCL isn't just one single disease. It's actually a whole bunch of different cancers that come from our mature T cells, the highly specialized soldiers of our immune system. It's not like the more common B-cell lymphomas. PTCL is, well, it's more like a really dysfunctional family of cancers where every single member behaves differently, unpredictably, and, unfortunately, aggressively. And this number right here really nails the core problem. We're talking about more than 30 different subtypes of PTCL. That's what the World Health Organization recognizes today. It's a true chameleon of a cancer. Each subtype can have a completely different genetic code, look different under a microscope, and react differently to treatment. So you can imagine that makes it incredibly tough to diagnose and even tougher to treat. So for years, with no specific drugs available for PTCL, doctors had to use what they had. The standard treatment was a chemotherapy regimen called CHOP. But here's the thing. CHOP was a total blunt instrument. It was basically a hand-me-down treatment borrowed from the much more common B-cell lymphomas. And yeah, as you'd expect, a one-size-fits-all approach that was designed for a totally different disease, it just didn't work very well. And the results? Well, they were pretty grim. The 5-year overall survival rates for patients on CHOP were stuck in this incredibly low range. I mean, it was a massive, flashing red light, a desperate signal that we needed a whole new strategy, a completely new way of thinking about this cancer. And we needed it fast.
So, clearly something had to give. The whole approach needed a rethink. Scientists realized they had to shift their focus, Move away from just treating symptoms and start digging deeper to understand the root cause, the actual genetic code that was driving these cancer cells. And you can actually see this evolution playing out in how we've classified the disease over the years. I mean, think about it. We went from knowing about just 11 types back in 1994 to over 30 today. And as our understanding grew, so did our technology. Things like next-generation sequencing, these were game changers. They let scientists peer inside the cancer cells and read their genetic blueprints for the very first time. And what they found was just fascinating. They started seeing the same mutations popping up again and again in a few key areas. So think of epigenetic modifiers as the software that tells a cell how to act. Well, in these cancer cells, that software is totally corrupted. Then you have things like TCR signaling, which is kind of like the cell's communication antenna. In this case, it's jammed in the on position, just constantly screaming, grow, grow, grow. The key here is that these weren't random mistakes. They were specific weak spots, giving researchers the first real, tangible targets to aim for.
And all this new understanding, it led directly to the first huge breakthrough. This was a pivotal moment, the first real proof that a targeted, precision approach could actually work against PTCL.
And that moment was the landmark Echelon-2 trial. It was a head-to-head battle. In one corner, you had a smart drug called brentuximab vedotin, or BV. Think of it like a guided missile. It's designed to lock onto a specific protein called CD30 that sits on the surface of some of these cancer cells. In the other corner, the old-school CHOP regimen. And they tested this in newly diagnosed patients, a real showdown.
Okay, so with the standard CHOP chemo, the median time before the disease got worse, what we call progression-free survival, was just under 2 years, 23.8 months to be exact. But with the targeted BVCHP approach, that number just skyrocketed. We're talking over 5 years, 62.3 months. This wasn't just a small bump. It was a dramatic, game-changing improvement. It proved that if you target a specific molecular feature of the cancer, you can change the entire story of the disease. So yeah, this trial wasn't just a success. It was a full-blown revolution. It completely changed the standard of care for a huge group of PTCL patients. But maybe even more importantly, it was the ultimate proof of concept. It proved that precision medicine could work here, and that just opened the floodgates for a whole new era of targeted treatments. And building on that incredible success, we have seen an absolute explosion of new therapies. I mean, scientists are now building a powerful arsenal of drugs designed to attack all those different genetic weak spots we found across the many, many subtypes of PTCL. Just take a look at these response rates.
And remember, these are in patients whose cancer has already come back after their first treatment. For a very long time, there was very little hope for these patients. But now, we're seeing entire new classes of drugs, things like epigenetic modifiers and signaling inhibitors, and they are showing real significant activity. I mean, some of these are getting responses in nearly 70% of patients. That's incredible.
So how do these things actually work? Well, this gives you a quick breakdown. Instead of that old carpet bombing approach of chemotherapy, these new drugs are like special forces. You have HDC inhibitors that basically try to reprogram the cancer cell to kind of remind it how to act like a normal cell again. Then you have JAK inhibitors that shut down a very specific communication line that's telling the cancer to just grow and grow. It's just a much, much smarter way to fight.
But what if we could go beyond even these clever drugs? The most futuristic approach isn't about a pill or an infusion. It's about turning the patient's own immune system into a living, breathing precision weapon. And yes, I'm talking about CAR T-cell therapy.
Now, you've probably heard about CAR T. It's been a total game changer for B-cell cancers. But for T-cell cancers like PTCL, there has always been this one massive roadblock: the problem of fratricide. Think about it. T-cells are killers. That's their job. So if you engineer a T-cell to go hunt down and kill cancerous T-cells, what's to stop it from killing all the healthy T-cells too? You could literally wipe out the patient's entire immune system.
The solution they came up with is just brilliant. It turns out a healthy person has a mix of T cells. About half of them have a protein on their surface called TRBC1, and the other half have one called TRBC2. But here's the key. A T cell cancer is clonal. That means all the cancer cells are identical. They're all TRBC1 or they're all TRBC2. And that's the opening. You just design the CAR T cells to target whichever one the cancer is, and you can wipe out the tumor while leaving the entire other half of the healthy T cell army completely untouched to fight infections.
And does it work? Well, the early results from a trial called AUTO4 are looking incredibly promising. Out of the first 10 patients they treated with this TRBC1 targeted CAR T, 7 of them responded. But get this, 5 of those patients, that's half, achieved a complete remission. I mean, all signs of their cancer just gone. It's early days for sure, but this shows that this amazing strategy has real, tangible potential.
So when you just take a step back and look at the big picture, the transformation in just a couple of decades is honestly stunning. We've gone from a shot in the dark with a blunt instrument that barely worked, to super specific drugs that target the cancer's genetic weak spots, and now we're literally engineering a patient's own cells into a living medicine. It's incredible.
It's a huge question, no doubt. But for the first time in all the decades we've been fighting this chameleon of a disease, it's a question that really feels less like an if and a lot more like a when.